Hello everyone. This is Lakshay Channa from Apollo Health City, Hyderabad. I welcome you all once again. Today we are going to talk about the basics of ECG. We'll discuss about the steps of reading an ECG. I chose this topic early in the series of podcasts because some of the residents actually came and asked for it, and I've also seen people approaching the consultants and senior faculty about teaching them how to read ECG, how to approach ECG, recommend some books, blogs on how to interpret an ECG. Now let's understand this is a skill which will probably take some time to develop, and it is hard to get it quickly and learn it overnight. But what we are going to do today is we are going to have a stepwise approach. We will discuss the stepwise approach to start with, and trust me, once you get the basics right, it is really easy to build on. What you need to do is practice, practice, and practice, and that's the key. What you need to do is see and try and interpret every ECG which you come across, and once your basics are clear, it is easy to learn ECG. Now, it took me a long time to understand the 12 lead ECG, the different waves, and trust me, if I can do this, anybody can do this. So this talk will make more sense to the first and second year residents. It can be emergency medicine, internal medicine, or family medicine residents who are really at a beginner level to learn about the ECG. I'm guessing this will take about 25 to 30 minutes, and as we go on I will also add additional resources and blogs. I will mention about them where you can learn the advanced stuff. You will also get a handout with this, the show notes along with this podcast. So before we jump into the steps of reading the ECG, let's understand why is this important for us as emergency physicians. Now, missed ACS accounts for about 20% of the malpractice, and 25% of these cases involve misreads of ECGs. It can be because of a delayed diagnosis, or it can be because of a missed finding on the ECG. So it is important for us to know this, to save us and to save our patients as well. Now, apart from the ACS, ECG changes can also be seen in respiratory system, CNS pathologies. The arrhythmias can also be interpreted on the ECGs, and you can also see ECG changes in drug overdoses like TCAs and antihistaminics, and electrolyte imbalances, hyperkalemia, for example. Now, this is how a normal ECG wave, PQRST, looks like. Now, remember here the P waves represent the atrial activity, the QRS complex represent the ventricular activity. So, if you want to look for atrial enlargement, you will look at the P wave. If you want to look for the ventricular enlargement, you will look at the QRS complexes. Anything above this baseline, this is called as the baseline, the TP segment, this one, or the isoelectric line. If anything is going above this, it is positive. Anything going below is negative. For example, P is a positive wave, R is a positive wave, T is a positive wave, U is a positive wave. Anything going below is a negative wave. So S is a negative wave. We also need to know the important intervals. For example, the PR interval, the PR segment, the QRS duration, and the QT interval. We'll discuss about them in step 6 as we go on. Now, let's look at this one big square here. We're talking about the horizontal axis. So this is the horizontal axis. So we'll see this one big square. It is comprised of 25 small squares. Or if I'm looking at the horizontal axis, I can just say on the horizontal axis, these 5 small squares, 1, 2, 3, 4, 5, the thin red lined 5 small squares make up this border of one large square. So one small square is equal to 40 milliseconds. We are talking in milliseconds. We will not put a decimal and confuse it with seconds. So just say 40 milliseconds, one small square, and one large square. This border of one large square is made up by 5 small squares. So that is 40 multiplied by 5. So that's 200 milliseconds. So remember, one small square, this one is 40 milliseconds. 5 small squares is 200 milliseconds. Just ignore this 0.4 seconds. It is actually 0.04 if you like decimal, and if you want to put it in decimal, this is a printing error here. So one small square is 40 milliseconds, or if you really like decimal, you can call it 0.04 seconds. One large square is 200 milliseconds, that is 40 multiplied by 5, because one large square is comprised of 5 small squares, and if you want to put this in decimal, this is 0.2 seconds. The paper moves at a speed of 25 millimeters per second. Okay, let's look at the vertical axis. This is the vertical axis. On the vertical axis, one small square is equal to 1 millimeter, and one large square is equal to 5 millimeters. So if I say 2 mm ST elevation, the ST elevation should be at least 2 small squares. If I say 5 mm ST elevation, so ST elevation should be 5 small squares or 1 large square. So this is how a normal ECG looks like. This is a 12 lead ECG, and different leads represent different walls of the heart. It is important for us to know this because changes in one particular set of leads can give us a hint about which part of the heart is involved, which artery is involved, which is the culprit vessel. So these are the augmented leads. This is lead 1, 2, 3, and these are the precordial leads V1 to V6. A quick mention about the progression of R wave here, normal progression of R wave. Now, you see in lead V1, we don't really see an R wave, and as we go from V1 to V6, the height of the R wave is increasing. There is no R wave here, only a deep S. Small r, it's getting bigger, it's getting here bigger, and it is dominant. It is the height of the R in V5 is more than the depth of S. They are almost equal in V4, and in V6 we don't really see S wave. So as we go from V1 to V6, the height of the R wave is increasing and the depth of S wave is decreasing. So this is called as a normal progression of R wave. This pattern can be disturbed in case the patient has a history of old entry wall MI. So that can disturb this pattern of normal progression of R wave. Let's go to the steps. So these are the 6 important steps: the rate, rhythm, axis, chamber enlargement, ischemia infarction, and intervals. Now there are many ways of reading electrocardiogram. If you want to develop your own approach and you are comfortable with that, that's absolutely fine, but this is very important. These 6 steps must be covered in whatever approach you have: the rate, rhythm, axis, chamber enlargement, ischemia infarction, and intervals. So we'll go through each one of them. Let's start with rate. So generally the computer tells us the rate, and it is right most of the times, but we should also know how to calculate the rate if we are given an ECG. So this is the normal ECG. You can see there are almost three large squares between these two RR intervals. This is R wave, this is R wave. Now the interval between these two is called as the RR interval. So there are approximately 3 large squares. So the formula to calculate the rate is 300 and divided by the RR interval big squares. So for example, in this ECG there are 3 big squares. So divide 300 by 3. The rate is about 100 beats per minute in this ECG. There is another formula if you want to be very specific. That's 1500 divided by RR interval. So if you take 1500 as the numerator, you will take the number of small squares. So 1, 2, 3, and one small one here. So 16 small squares. That is the 3 big squares, 15, and this one small square. So 15 plus 1, 16 squares. So 1500 divided by 16. So that comes in about 90s. So to be very specific, the rate is little less than 100. It's somewhere around 9500 on this ECG. So that's all about the rate. 300 divided by the RR interval. If you take 300 as the numerator, take the big squares. If you take 1500 as the numerator, take the small squares to get your rate. And we have already talked about this. One small square is equal to 40 milliseconds, and one large square is equal to 5 small square. That's equal to 40 into 5. That's 200 milliseconds. Let's talk about the rhythm. Now you need to ask yourself, you need to see for 3 things when you look at the rhythm. 3 questions you need to ask. One is there a P wave? If P waves are present, then the rhythm is sinus, and if the P waves are absent, the most likely arrhythmia is the atrial fibrillation. That's the most common arrhythmia. Then you need to look at the QRS width. It's narrow or wide. The normal width of the QRS complex, I will just go back to this slide. The normal QRS duration is just under 3 boxes. So one box is 40 milliseconds. So 3 boxes are 120 milliseconds. So normal duration of QRS is about less than 120. So if QRS duration is less than 120 or less than 3 small boxes, you will call it a narrow QRS. If it is more than 120, that is more than 3 boxes, 3 small boxes, you will call it a wide QRS or broad QRS. And next is the RR interval. You will look at if it is regular or irregular, and that's all rhythm. Just 3 questions. Look at the P waves. If P waves are present, the rhythm is most likely sinus. If the upright positive P waves are present and P waves are absent, the most common arrhythmia is atrial fibrillation. QRS width, it is important when you're looking at the tachyarrhythmias, which we will not talk about today. If it's a narrow complex tachyarrhythmia or if it's a broad complex or wide complex tachyarrhythmia. The R interval, again, it's to look at the rhythm, whether the rhythm is regular or irregular. Let's go to step 3, axis. So we'll just touch on this, how to determine the axis. Now the normal axis lies somewhere between minus 30 to 100, 110 degrees. You just need to look at 2 leads to pick up your axis, to determine the axis. If we go back to this ECG, you just need to look at 2 leads, and these 2 leads are lead 1 and lead AVF. Just ignore the rest of the 11, the rest of the 10 leads. Just look at lead 1 and lead AVF. Okay, so you know what is a positive complex now. Anything going above the baseline or isolated line is positive, anything going down is negative. So in lead 1 and lead AVF, if the complexes are positive, if the QRS is positive in lead 1 and AVF, that's the normal axis. Okay, so in this we have a positive QRS in lead 1 and we have a positive QRS in AVF. So this is the normal axis. If the QRS is positive in lead 1 and if it is negative in lead AVF, so that's called as the left axis deviation. So you can remember like this, say this is the baseline and the QRS in lead 1 is up, it's positive, and QRS in AVF is negative, so they are pointing away from each other. So that's a left axis deviation. So left leaves left axis deviation. If QRS is negative in lead 1, that's pointing down, and if QRS is positive in AVF, that's pointing up. So they are pointing towards each other, so right reaches. That's right axis deviation. So just remember how to look for left axis deviation and right axis deviation. I'll also show you one example. This is another picture. The normal axis lies somewhere between this, that's minus 30 to 110. Okay, so let's look at this ECG. We will see only 2 leads. This ECG is showing us left axis deviation. We'll see only 2 leads, lead 1 and lead AVF. This is positive in lead 1, it is going up, negative in lead AVF. So this is going up, positive, this is negative. They are leaving each other, the arrows are pointing away from each other. This is going up, this is going down. So we know left leaves, this is left axis deviation. Okay, we'll look at this again in lead 1. It is coming down, it's very subtle, but it is down, it's pointing down. Lead AVF is pointing up. So they are reaching towards each other. It is coming up, it is coming down. So right axis, so right reaches. So this is right axis deviation. Okay, again remember this, lead 1 positive, AVF positive, normal axis. Lead 1 positive, AVF negative. They are leaving each other, they are pointing away from each other, left axis deviation. Lead 1 negative, AVF positive, so they are pointing towards each other, so that's right axis deviation. That's all about the axis. Let's move on to the chamber enlargement. So we'll go through the 4 chambers. We'll start with the left ventricle, because left ventricle hypertrophy is seen very commonly, and as when we cover this, we'll do the rest of the 3 chambers. So let's talk about the left ventricle enlargement. So there are different criteria to call it left ventricular hypertrophy, because of the voltage, because of the high voltage of the complexes. Now we know this is ventricular enlargement, and we will look at QRS, because QRS represents the ventricular activity. If we are looking at atrium, we will uh, talk about the P wave. So this is the criteria to call it LVH by voltage criteria. So if you see R wave in V5 or V6 and you add S wave in V1, the sum is more than 35 mm or 35 small boxes, because one small box is 1 mm. We have seen this on the vertical axis. If the sum of these two waves is more than 35 mm, then it is suggestive of left ventricular hypertrophy with voltage criteria. Now this is not 100%. Some patients may show these changes without actually having a LVH, and all the patients with LVH may not show these ECG changes. So let's see how we calculate this 35. So this is a deep S wave, lead V1, and this is a tall R wave in V6. Now we will take the R in V6, we can take anyone, V5 or V6. So R wave in V6, that's how many boxes? 1, 2, 3, 4, 5, 6, just more than 6 boxes. So we'll take it 6 boxes, 6 large boxes. That's about 30 mm. 5 into 6, one large box is 5 small boxes. So this height is about 30 millimeters. We'll see the depth of the S wave in V1 now and add both of them together. 1, 2, 3, 4, just about 4 large boxes. So that's about 20 small boxes. That's equal to 20 mm. So this is 6 and 4, so 30 plus 20, so this is about 50 mm. So that's more than 35. So this ECG we can interpret as ECG is suggestive of left ventricular hypertrophy by voltage criteria, because the voltage here is high of these complexes. That suggests LVH. So that's all about left ventricular hypertrophy. There are different criterias. We have used this one. If you want to remember the names, you are free to do that. But remember, this is the most commonly used criteria, the Sokolow-Leon criteria, the most commonly used criteria. Okay, let's go on to the right ventricle. Again, we will look at the QRS complex, because we are still talking about the ventricles. This is simple as compared to the left ventricle. You will see the height of the R wave in V1. Now we know in this ECG, say for example, the progression of R wave is normal. There is no R here, and it is growing taller as we are going to V6. But here, to start with, in V1 there is a dominant R wave. So that is suggestive of RVH, or right ventricular hypertrophy. So dominant R in V1 is one sign. Or if it is more than 7 small boxes or 7 mm tall, it is again suggestive of right ventricular enlargement. Or if the R by S ratio is more than 1, you can calculate the R ratio in V1 and the S ratio in V1. Then you can divide them, and if you get a number which is more than 1, that is suggestive of RVH. So you can remember dominant R in V1 or more than 7 mm, or if you want to divide, for example, the height of R is 7 mm and the depth of S is 2 mm here, so 7 divided by 2, it is 3.5, so that's more than 1. So that's again suggestive of RVH. So remember any of these three, and that's about the right ventricle. Let's go to the left atrium. So left atrial hypertrophy, we will look at the P waves now. We were talking about atria now. So a bifid P wave in lead 2 is suggestive of left atrial hypertrophy or left atrial enlargement. So the best leads to look for P waves is lead 2 or lead V1. We will focus on lead 2 here, and a bifid P wave. Now I'm not sure if you can appreciate this, but the P here, you can look at the pointer which is towards north, and there is a bifid. There is a notch on the P wave here in lead V2. So this is showing a better picture. Now you can see normal P wave is nice and curved, but there is a notch here. So this is called as bifid P wave. It is suggestive of left atrial enlargement, and it's also called as P mitral. So bifid, a notched P wave in lead 2. Remember, this is only in lead 2. When we're talking about P waves, we are looking at lead 2. So that was about the left atrial enlargement or left atrial hypertrophy. Now the right atrium, this is the last chamber we are left with. Again, we'll look at lead 2. This is lead 2, lead 3, AVL, AVF. Now there it was the notch on the top of the P wave. Now in case of right atrial enlargement, the height of the P wave increases. So if it is more than 2.5 mm, 1 mm is one box, 2.5 mm is 2.5 boxes. So if the height is more than 2.5 mm, that is suggestive of right atrial involvement or right atrial enlargement. This is definitely more than 2.5 mm. Okay, again you can see here the P is looking, it's pointed. Normally it is nice and curved, but in lead V2 it is pointed. So this is more than 2.5 mm. So this covers the chamber enlargement. We have talked about LV, RV, LA and RA enlargement. Remember, ventricles is the QRS complex, atria is the P wave. Let's talk about the ischemia and infarction part. I would say this is the most important part because we do ECG for every patient with chest pain, and what we want to rule out first is acute coronary syndrome. So ischemia, the traditionally described findings are T wave inversions and ST depressions, and infarction will have ST elevation. And these are the different leads which represent different walls of the heart. So remember, this is lead 2, 3, AVF. These represent the inferior wall. So if I see changes here, if I see ST elevation here, I would say this patient has got inferior wall MI or inferior wall ST elevation MI or inferior wall infarction. If I see changes in V1, V2, V3, V4, I know the anteroseptal part is involved. If I see 1 and AVL and V5, V6 involvement, ST elevation in these leads, I will call it lateral wall MI. Or if only lead 1 and AVL is involved with other leads normal, some people call it high lateral wall MI, if only lead 1 and AVL is involved. So it's important for us to know which leads represent which part of the heart. So let's look at some example. This is anterior wall STEMI or anteroseptal STEMI because there is ST elevation in V1, V2. This is the baseline. This is about 5 mm ST elevation, V3, V4, V5, V6, and also the lateral wall also looks a bit involved here. There's ST elevation in lead 1 and AVL2 if you just observe. So it is anteroseptal lateral wall MI. 1 AVL, V1 to V6, there is ST elevation all over, and you can see the reciprocal changes, the ST depressions in lead 3. Another example, this is the high lateral MI. You can see ST elevation in lead 1 and AVL, and these are the reciprocal depressions here. Okay, and another example, this is inferior wall MI. You can see the ST elevation in inferior leads, that's 2, 3 and AVF. These three are the inferior leads with reciprocal ST depressions and inversions, T wave inversions in the AVL. So this is inferior wall STEMI because inferior leads are showing changes. And we talked about infarction. If there is not a complete block, if the occlusion in the coronary is not complete and it's partial, the described changes are ST depressions or T wave inversions. That can be NSTEMI or an unstable angina based on the troponins. So you can see T wave inversions in V2, V3, V4, maybe V5. So these are the findings which suggest ischemia rather than infarction, the T wave inversions and the ST depressions. Now just a quick note here about the cause of ST elevation. The causes of ST elevation can be many. ST can go up because of a whole lot of reasons. A common one is STEMI. You need to know the other causes also, because it is important for us to understand every ST elevation does not represent acute coronary syndrome. Your history is very important. If your patient comes with ankle pain and he's going for surgery and you do a pre-op ECG and that shows ST elevation, don't just call the cardiologist. Just it's a good idea to get some history from these patients. So remember, every ST elevation is not ACS. The important causes from emergency medicine perspective is ST elevation, MI. The other ones are, it can be ventricular aneurysm, it can be hyperkalemia, Brugada syndrome, or left bundle branch block. So all these can cause ST elevation. So remember to get some history on these patients before you call your cardiologist. That was about the ischemia infarction, and this is the last step. We are almost done. We are 26 minutes into this, and the machine generally, the computer gives you these values: the PR segment, QRS interval, and the QTC segment, the corrected QT interval. Now the normal PR segment is 3 to 5 small boxes. One small box is 40 milliseconds. So 3 small boxes, it's 120 milliseconds, and 5 is 200 milliseconds. So anything more than 200 is abnormal. And the QRS duration is less than 3 small boxes, 3 thin walled, thin bordered small red boxes. Anything more than 3 small boxes is a wide or broad QRS. This is important when you're looking at tachyarrhythmias, and the PR segment is important when you're looking at the heart blocks, whether it's a first degree, second degree, or third degree heart block. Now the QTC can be prolonged because of a whole lot of reasons. It changes with the age and gender. So there are different formulas to calculate the QTC. I generally rely on the machine for this. Anything more than 500 is clinically significant. Now there are different values mentioned in different texts, like 440 and 460 milliseconds for males and females. I generally follow this 500. It is easy to remember, and anything more than 500 is clinically significant. You need to find out the cause. Now again, there can be a whole lot of reasons for a prolonged QTC interval. You need to get history. Drug history is important on these patients, because drugs like antipsychotics, antihistaminics, antibiotics can prolong your QTC. So get a history, find out the cause, and treat the cause of prolonged QTC. And remember, machine is usually right with these intervals, and you can trust the machine. So these are the 6 take-home steps from this session: the rate, rhythm, axis, chamber enlargement, ischemia infarction. Now trust me, if you follow this, it is unlikely that you will miss anything on the ECG. It is unlikely that you will miss a block with the inferior wall MI if you follow these steps. So follow these steps, see more and more ECGs, practice, 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 and that's the key. I will also give you the handout, the show notes with this podcast. These are some online resources: the Life in the Fast Lane and the ekg.umem, which has some great ECG videos. Once you are done with this, you can start following this and build on your basics. Thank you all. If you have any questions or feedback, please email me, or you can put on our Facebook page. Thank you for your attention, and we'll come with some other very interesting topic next time. Yeah, thank you. Bye bye.